Medurstand. Understanding Medicine.
Professor Aziz-ur-Rehman here. We have covered one main condition out of this group of disorders called myeloproliferative disorders. We have covered chronic myeloid leukemia in detail. As these presentations, these videos are basically meant for internists or younger physicians, so I will restrict my talk to a certain level, and I'm going to cover remaining three conditions out of this group: Polycythemia Rubra Vera, essential thrombocytosis, and myelofibrosis, all three conditions in one lecture. This is the classification I shared with you earlier. This is hematopoietic stem cell, and these are supposed to be monoclonal disorders. At a certain level of maturation, one particular cell gets mutated, and the progeny, the cells which derived from that cells, they get malignant. So basically there are two groups: lymphoid series, this would be lymphoproliferative disorders, chronic lymphoid leukemia, and non-Hodgkin lymphoma and Hodgkin lymphoma. These would be discussed in subsequent videos, but these days we are covering this myeloid series, myeloproliferative disorders. As I just said, we have covered chronic myeloid leukemia, but these three conditions, polycythemia vera, essential thrombocytosis, and myelofibrosis, these three conditions will be discussed today relatively briefly, because the basic principles, the pathogenesis is the same as was discussed in some more detail in chronic myeloid leukemia. If you have not watched that video earlier, you could go back and see that video and then come here again. Polycythemia Rubra Vera, previously it used to be called polycythemia. Polycythemia means excess of RBCs. Rubra Vera, rubra is red complexion, red and bluish complexion which these patients develop. Vera, I think probably idiopathic. I'm not sure what is meant by Vera, but these days they call it Polycythemia Vera simply. But please note down, much commoner condition is secondary polycythemia, which is usually as a result of chronic hypoxic state, either chronic obstructive airway disease, interstitial lung disease, pulmonary fibrosis, or maybe some right to left shunt like Fallot's tetralogy or Eisenmenger complex. So secondary polycythemia would be much more commoner. So I think whenever we see a patient with polycythemia, our first reflex is to rule out secondary polycythemia. And if there is no clinical reason to suspect polycythemia, we still do some tests to rule out secondary polycythemia before we label this patient as a case of polycythemia vera. There are certain diagnostic criteria. None of them is absolutely essential. I'll just share with you all those criteria and then we can move on to the next condition. So salient features of polycythemia vera. Number one, no cause. No cause for polycythemia. Of course, there is a cause in these patients. There is some mutation, and why that mutation occurs we don't know. Maybe some viral infection, maybe ionizing radiation, maybe exposure to some other thing, but there is some mutation. But when I say no cause, that means no cause for hypoxia, no cause for polycythemia. So that means it has to be primary polycythemia, not secondary. So this means we have to rule out secondary. In primary, there is no known cause. And HB and hematocrit are increased. Either hemoglobin or hematocrit, they should be increased. Remember, in normal healthy individuals, there is a lot of variation. HB in men may be slightly more than HB in women. Similarly, hematocrit. There is a wide range. Healthy people may have hemoglobin of like 12 and may have like 15, 16. Similarly, hematocrit. So I think we need to see that HB or the hematocrit is significantly higher than the upper normal range. Then in some cases there may be splenomegaly. In secondary polycythemia, whether it is due to lung disease or is it due to primary heart disease, the chances of splenomegaly are very little unless patient has got endocarditis. So splenomegaly, whether that is clinical finding or you detected splenomegaly on ultrasound or some other imaging technique, so presence of splenomegaly in patient with polycythemia, in patient with increased HB and hematocrit would very strongly suggest the possibility of polycythemia vera. Erythropoietin is suppressed. This may not be a very sensitive test, but basically what we want to know is that there is no cause of increased erythropoietin. The commonest such possibility would be chronic hypoxic state. So in chronic hypoxic state, erythropoietin is increased. In fact, it is the erythropoietin which stimulates bone marrow to produce more RBCs as an attempt to correct hypoxia. That is the pathogenesis of secondary polycythemia. So in these patients, erythropoietin would not be elevated at least, but it may be suppressed. So I think if you find erythropoietin level to be low, that would be one point in favor of polycythemia vera. Then JAK2 mutation, like we discussed in chronic myeloid leukemia, there is a mutation. Here also there's called Janus kinase 2 mutation. This mutation can be detected by specialized techniques. So if you suspect polycythemia vera, I think it would be right to send the sample to a specialized hematology lab for JAK2 mutation. Please note down, there are cases where JAK2 mutation may not be detectable because there are a number of actually JAK2 mutations and other mutations which can cause polycythemia vera. So the available tests for JAK2 may not detect the mutation. So we expect that test will be positive. If JAK2 mutation is detected, our diagnosis of polycythemia vera would be strengthened. But if everything else is suggestive of polycythemia vera, a negative JAK2 should not rule out this diagnosis. Conversion. Now that, I think this point I highlighted in my earlier lecture also. All these conditions which come under polycythemia, this myeloproliferative disorder, one can convert into another one. For example, polycythemia vera may later become myelofibrosis, or chronic myeloid leukemia may arise from polycythemia vera, or patient may develop acute leukemias, because those mutations, if not checked, they can cause further malignancies. And then treatment, previously, I think even these days, whenever we treat these patients, our primary aim is to reduce red cell mass, just to make the blood flow more physiological and to avoid any clotting, thrombosis. So I think one way was to ask patient to donate 1 pint of blood every 2 to 3 months. That would depend upon how high the HB is and how this patient tolerates phlebotomy. So it is recommended that these patients should give blood every 2 to 3 months to keep their hemoglobin in a safe limit, which I would consider like 14. So 1 or 2 pints of blood may be given away to bring down HB, because these cells, the patient, though theoretically this is a malignant state, but the prognosis is generally very, very good. Having high count is a problem, but if you can reduce the count to a more physiological state, patient can live almost normal life. So phlebotomy is a very, very acceptable solution. Now, I'm not sure what would you think, but since these cells, the cells present in the peripheral blood, they are mature cells, they are not malignant cells, they, to my understanding, cannot transfer polycythemia vera to another person. So I think if there is a blood ABO compatible, blood group compatible recipient who needs this blood, perhaps this blood can be donated to a recipient. But I respect your opinion. Some would be apprehensive to receive such a blood, but I personally think that this is okay to donate this blood. At least this blood can be used to separate other uh, components like clotting factors, albumin. So I think this donated blood goes to the laboratory and it is used for other purposes. Please note down one of the treatment principle is to keep their HB low. So I think it is also a general practice to keep these people slightly iron depleted. So I think they should be told not to take iron supplement. Of course, you know, iron is not only required for RBC production, it has got many other functions, but I think if you restrict iron, patient will still be taking sufficient iron, which is enough to fulfill other requirements. Now then some people may not may be fit for this or may not respond to this. Then we can give them some drugs. These are actually called cytoreductive therapies. That means our aim is not to achieve remission, not to cure leukemia, but our aim is just to reduce red cell production. So I think this can be combined with phlebotomies. Hydroxyurea can be given to reduce red cell production. And then JAK2 inhibitors. Now we have very luckily JAK2 inhibitors. So these drugs, if available, can be added to the existing therapy like phlebotomy, hydroxyurea, or of course JAK2 inhibitors can be given straight away. These JAK2 inhibitors are expensive, and since the prognosis is otherwise very good, so I think only when you see that the response is not good to these, maybe you can consider JAK2 inhibitors. One such inhibitor is called Jakavi. And what are the diagnostic criteria? What are the diagnostic criteria of polycythemia vera? HB should be more than normal. If you consider 15 or 16 as upper limit, then anything more than 16 like 17, 18, 19, 20 like that. Of course, it cannot be very high because that would cause clotting. So I think for anything between 16 and 20, I would say would be very suggestive of polycythemia vera. In women 16 and in men at 16.5. JAK2 mutation, if demonstrated, that will add weightage to the diagnosis, and there should be no hypoxia, and patient should have to rule out hypoxia. I think if you demonstrate that this saturation is a very easily available test you could do in your clinic. So if the oxygen saturation is pulse oximetry is 92% or above, that means there is no hypoxia. Or at least there is no sufficient hypoxia to justify polycythemia. Bone marrow examination is not done very often in these conditions because diagnosis is quite obvious otherwise, but if done, it would show hyperplasia, particularly of red cell series. Now, if patient has an overlap syndrome, then you would have hyperplasia of other cell series also, maybe a lot of fibrosis also. That would depend upon individual to individual patient. So that was all about essential the polycythemia vera. Now we take up another condition, and this is essential thrombocytosis. Very similar to the previous one. In the previous one you had more number of RBCs, more RBC mass. Here you have more platelet. In this mutation process, the cell which was actually hematopoietic cell, which was specialized, which was specially designed to make platelets, that got mutation, and that resulted in formation of too many platelets that resulted in essential thrombocytosis. Like in polycythemia, there are many conditions where there is this thrombocytosis or maybe thrombocythemia. Like in many infections, many traumas, there may be just transient elevation in platelet count. Please do not jump to the diagnosis of essential thrombocytosis or essential thrombocythemia just on one reading. Unless that reading, the platelet count is more than 1000. Normal range is 150 to 450. So if the count is very high, maybe you can make a diagnosis of essential thrombocytosis in one reading. But mostly I think it is, if it is between 450 and 1000, I would suggest that observe it over a period of maybe 1 or 2 months. And if this abnormality persists, then you should label this as essential thrombocytosis or thrombocythemia. Some components, some essential components. One is platelet count is persistently elevated, right? Way above 450. Like I think I would say at least 600, 700. Many times we make a diagnosis and we do not take an action because just like polycythemia, many these patients, they have a very normal life expectancy. So we note down the count and may not take any further action. Megakaryocytic hyperplasia, if you do bone marrow, megakaryocytes are precursors of platelets. So I think they would be hyperplastic and you may see too many and too big megakaryocytes. Then conversion, just like other condition, they could have conversion to another myeloproliferative disorder. So I think you have to be watchful. In treatment, we normally recommend antiplatelets. The problem with essential thrombocytosis is that this can predispose to not only thrombosis but also bleeding. So this is a little tricky. If it was just thrombosis, then I think we would be very keen to give antiplatelet, maybe a double antiplatelet. But since these patients are sometimes prone to develop bleeding also, so it's not a very simple and straightforward case. But we do prescribe antiplatelets, maybe double, and the aim is to reduce the platelet aggregation. So there is increased number, but we reduce their aggregation so that this clot do not develop. Then is myeloproliferative disorders, myelofibrosis. You know, we have various components. Fibrous tissue is also the fibrous tissue of the bone marrow is also one of the components which can get hyperplastic and it may lead to an abnormality. Now, fibrous tissue is generally taken as a connective tissue or just the background tissue, but here it may play an active role. So if the fibroblasts, they start proliferating, they will take up bone marrow space. Now, as it takes up more and more bone marrow space, the all cell series, white cell series and red cells and platelets, they're all reduced. So there is a sort of pancytopenia. In these conditions, lymphocytes may not be significantly low because lymphocytes are produced in extramedullary tissues also, like spleen, like liver, like lymph nodes. So there is not only pancytopenia, there is a reversal of polys and lympho ratio. So one is this marked pallor. These patients are typically very frankly anemic because the bone marrow is occupied by fibrous tissue. HB is typically very low. And since these patients have pancytopenia, they would have not only pallor, they would have some bleeding, and they may also have ecchymosis. So, and there may be massive splenomegaly. Typically in myelofibrosis, spleen is very, very big, just like chronic myeloid leukemia, maybe even bigger. So spleen may be so big that it occupies the whole of the abdomen. Sometimes it can go up to the right, like fossa. So that is one very helpful diagnostic feature. Then there is pancytopenia, and pancytopenia, that means TLC will be reduced, RBC count will be reduced, and platelet will be reduced. And as I just mentioned, polys lympho ratio will be reversed. Normally we have about 60-70% polys and about 30% lymphos. Now in these patients, because polys are reduced, lymphocytes are not reduced, so the ratio would be reversed. It could be 50-50, it could be 40-60, it could be 30-70 or whatever. So total number will be obviously 100, but close to 100, including other cells. But I think you need to understand that the cause of reversal of poly-lympho ratio is reduction in polys. Lymphocytes are actually normal. Don't make a diagnosis of lymphoid leukemia if the lymphocyte count is increased, because then you would have other picture in the peripheral blood. Of course, there may be a difficult case where it is not clear, but just on the observation the lymphocyte count is increased, you should not make a diagnosis of lymphocytic malignancy. Then on bone marrow examination, there is fibrosis. If you do bone marrow aspiration biopsy, you may not get the bone marrow tissue, and that is described as dry tap. The commonest reason of getting a dry tap may be a faulty technique and you were not actually in the bone marrow. But if you are an expert, a hematologist or internist, and you have experience of doing bone marrow examination, but despite proper technique, despite the fact that you were in the bone marrow, the tip of the needle was in the bone marrow, you don't get anything that is called dry tap. That means there is no live bone marrow tissue. All you have is fibrous tissue. And fibrous tissue cannot be sucked into the needle, so you don't get anything. Then conversion in myelofibrosis also. The chances of myelofibrosis getting converted into other condition is less, but there is a chance of developing acute leukemia in the background of myelofibrosis. So if you happen to see that case late, then you might just be able to diagnose acute leukemia, and later on further testing you realize it was actually a case of myelofibrosis. One way to differentiate would be you don't expect massive splenomegaly in acute leukemias. So somebody has acute leukemia picture, but spleen is very big. I think that would suggest that this acute leukemia developed in the background of chronic myelofibrosis. And the treatment, the curative treatment on all these myeloproliferative disorders is bone marrow transplantation. Either the recipient gives bone marrow as a tissue, or we take hematopoietic stem cells from the donor and then transplant them into the recipient. Of course, this is a very, very promising technique, and though the availability of this is not universal in our countries, I understand there are only few centers where this treatment is offered, but this of course is very, very good treatment. It would require a donor and then transplantation treatment, and then after transplantation then there would be of course long-term treatment to prevent rejection and also host versus graft disease. So that was it. I would like to thank all of you to watch this video, and I hope it gave you reasonable understanding of these three conditions. I again say that if you missed my earlier video on chronic myeloid leukemia, you should watch that and then come here, then take this lesson, and that will cover the module of myeloproliferative disorders. Thank you very much. This has been Professor Aziz-ur-Rehman from Medurstand. I really look forward to see you in my next video. That would be on lymphoid disorders. Thank you very much.